My name is Lidia Nunez de la Torre. I'm a Hamilton Scholar here at FIU. I'm interning at the office of Congressman David Valadeo, representing the 22nd District, and I'm majoring in psychology and statistics with a strong interest in resilience and health. We're excited that you're joining us in the launch of our Population Health Initiative and today's dialogue on climate and health. For those joining us in person and those joining us online, we're eager to explore how we can all collaborate to address the challenges before us. We know that evolving climate conditions are exacerbating health threats and create new public health challenges. In addition to learning some, we would like today's discussion to be forward-thinking and action-oriented. So please feel free to take notes, and also please discuss with each other on our breaks on actual ideas for greater collaboration across different sectors. It is now my pleasure to introduce our Vice President of Research, Dr. Andres Gil.
Thank you, everyone. I'm on the clock because Carlos said get up and start walking. So welcome and thank you for joining us here at FIU. We are excited about our Population Health Initiative, and I'll be brief or Carlos will come and remove me from the podium. Our perspective on population health, and I know that there are many definitions that we discussed earlier today, is that it consists of interrelated conditions and factors that influence the health of populations over the life course. We know we will need to identify systematic variations in patterns of occurrence by groups and geographies, and then apply the resulting knowledge to develop, implement, and evaluate policies to improve the health and well-being of those populations. I believe that FIU is in an excellent position to cultivate team science, to expand research, to develop comprehensive approaches to improve health outcomes with broader societal impact. We will be focused on upstream approaches to addressing population health, and we will try to break the silos by having an initiative rather than a center or an institute, so that we can get the entire FIU community and the community in South Florida and partners nationally and internationally to work with us. Health and environment are two strong pillars of research and education at FIU. So again, this is really a natural progression for us. We want to operate outside cycles of research funding, like a 5-year NIH grant, and then we move on to other things. We want to have a consistent approach. Our president and provost are supporting this as a 20-year initiative for the university. So we will have the flexibility to embark on sustained efforts that are not constrained by those funding cycles. We will bring collaboration across disciplines to address population health challenges. This afternoon, here you will have an opportunity to meet many of our faculty fellows that are coming from all areas of the university. We have members of the National Academy of Medicine that are FIU providing leadership for this initiative, and we are embarking on a national search for a director. So you can look up at somewhere on the website at FIU that we are announcing looking for applicants. We're looking for partners, and one such partner we have is the University of Washington, who has a well-established population health initiative. So I would like to now introduce the president of the University of Washington, who was unable to join us here, but has a brief message. Dr. Krause became the 33rd president of University of Washington in 2015. In 2020, she was elected to the American Academy of Arts and Sciences. And in 2022, she was elected to the National Academy of Medicine in recognition of her leadership in health education, research, and service systems, as well as her pioneering research in behavioral health. Dr. Krause was raised in Miami, so this is a very natural collaboration for us. So Ana Mari, welcome, and thank you.
Thank you, Dr. Gil, and hello to everyone from the University of Washington, the other Washington. And I'm sorry that I couldn't be there in person in your Washington today, but I'm honored, I'm delighted to be taking part in this very, very important event. And congratulations to everyone at Florida International University on the launch of your population health initiative. As you've been talking about this morning, the health of people and communities everywhere depends on a complex web of environmental, socioeconomic, and human health factors. And as you know, no single discipline can tackle all of those challenges. But through collaboration, impact is possible. We can make a difference. And with this new initiative, FIU is stepping up as a critical leader in this space, not only through your scientific and scholarly expertise, but through your capacity as a top public research university to convene and catalyze collective effort. Here at the University of Washington, we launched our population health initiative in 2016, and we viewed it also, like you, as a multi-decade effort to improve the health of all communities. Rather than simply expanding on the traditional medical model that focuses on the health of individuals, we envisioned a model that more effectively worked across all the factors that affect people's health and well-being. We launched ours just before the pandemic. And at that point, it was kind of hard to explain to people what we meant by how the health of anybody can affect the health of everybody. But the pandemic really brought that lesson home. And now we all understand that. And through our population health initiative, we've thought to leverage our deep expertise, the service capacity of our academic healthcare system, and the extraordinary concentration of major organizations in our region. And you have many of those same assets. In the 8 years since we launched our initiative, we've seen how effective this model can be at driving a comprehensive and interdisciplinary approach to solving health problems that's broadly defined. We've seen the power that comes when faculty and staff across our campuses works together. And we've seen how exposing students to the cutting edge work of tackling grand challenges inspires them. And, as we know, young people understand how urgent this moment is, and they need inspiration. And this model gives them that inspiration. We've convened stakeholders to co-create pilot programs, and then we've accelerated them to show how they can have an impact on a larger scale. Now, since we've launched, and you know that in academia, 8 years is not that long, we've engaged more than 18,000 students and nearly 1,800 faculty. We funded 364 student awards and 196 faculty projects. And that's led to engagement with about 2,000 separate community-based organizations. We really are having impact. And for every dollar that we've invested in a faculty project, it's returned more than $4 for a total of $30 million, which is, this is an investment in our future. And the success of our population health initiative has encouraged us to use it as a roadmap for tackling other grand challenges. And we're really excited that it sparked this incredible collaboration with you at FIU. As Dr. Gill said, I grew up in Miami. And so this is so wonderful and so close to my heart. And when you think about it, we are the perfect partners. We're at opposite ends of the world and of the country, at least. When I moved out here, my mother said, "You're moving as far away from me as you possibly can." I had to say, not on purpose, which is true. But think about it. When we hold hands, we really are boundless. We bring together all of the US, and we point out across the Atlantic and across the Pacific. The power of our partnership truly is amazing. And I am so, so excited about what we're going to do together. So as you all begin your exciting journey, all of us at the UW are rooting for your success, and we can't wait to see what we will accomplish for health and well-being of people and communities everywhere. We look forward to collaborating with you, to share our experiences, and to learn from yours as your initiative takes shape and takes off. Our world faces big challenges, especially in the realm of climate and health. As the saying goes, though, if you want to go far, if you want to go fast, go alone. But if you want to go far, go together. And that's exactly what we're going to do. We're going to go forward together. We're going to make a difference, and we're going to have fun as we do it. So congratulations again. And now I'm pleased to turn things over to Dr. Jean Miranda, Distinguished Professor at FIU.
It's an honor to introduce Admiral Rachel L. Levine, who serves as the 17th Assistant Secretary for Health and for the U.S. Department of Health and Human Services, and the head of U.S. Public Health Service Commissioned Corps. Admiral Rachel L. Levine storied career first as a physician in academic medicine, focused on the intersection between mental and physical health, treating children, adolescents, and young adults. Then, as Pennsylvania's Physician General and later as Pennsylvania's Secretary of Health, she addressed COVID-19, the opioid crisis, behavioral health, and other public health challenges. The Assistant Secretary has helped launch many of the administration's bold steps to address today's challenges, most importantly, establishing an Office of Climate Change and Health Equity, which also coordinates a quarterly climate and health outlook, which has provided for you today. Admiral Levine.
Well, good afternoon, and it's great to be here with Florida International University, and thank you for that introduction. As we have witnessed with a string of climate-related disasters in 2023, climate change is having serious impacts on the health of people in the United States and around the world. Climate change is a public health crisis right now. These problems will get worse as climate change accelerates unless strong actions are taken by the health sector to build resilience to the impacts of climate change and actually to combat climate change itself. NASA has confirmed that the summer of 2023 was the hottest summer on record. But we need to understand this in human terms for people living in this country and around the world. There were over 300 heat-related deaths in Maricopa County in Arizona so far this year. On a given summer day, half of the people in the country are under heat advisories, and heat-related visits to the emergency department increased 2 to 3% every year. These statistics translate, though, to real-life impacts on our communities. So I was in Orlando a year or so ago and heard from farm workers in Orlando, and what they tell each other and their families is that they leave their kidneys in the fields. Because of the impacts of extreme heat and dehydration, it's common to have significant renal damage. They leave their kidneys in the fields. I've heard from tribes in rural Alaska who are on the front lines of climate change in Nome, in Utiavik, in Savunga on St. Lawrence Island. They are watching the permafrost melt under their feet. We were able to tour one of the villages on St. Lawrence Island, Savunga, and we saw houses that are at 45-degree angles because they are literally falling into the permafrost, sliding into the ocean. And their native food sources are migrating to colder climates up north. They face decisions about buying expensive canned goods that actually have to be flown in or to use that same money on hunting supplies. Their native food sources are also consuming increasing contaminated food and water, leaving people to pick between diabetes from canned goods or cancer from their native food sources. This has led to dramatic increases in mental health issues, as well as substance abuse issues. These sound like stories that couldn't possibly happen to us, but in different parts of our country, they are happening right now. And they will be all of our future realities if we are not able to start to get climate change under control. Heat alone creates huge burdens for communities and healthcare providers, but the challenges do not stop there. We have also been certainly exposed to smoke from wildfires, and we saw that last summer right here in Washington, D.C., and then the same thing in New York City. It's common out west, not so common right here in the east. There is not a state in the country that does not experience extreme heat or catastrophic weather events or more in recent months and in recent years that impact health in so many ways. Threatens older adults who have cardiovascular disease and respiratory disease. It threatens mothers and babies. It threatens children and adults who have asthma. It broadens the area where we see vector-borne diseases, such as mosquito-borne diseases, dengue, throughout much of South America, spreading northward. It causes displacement of people and climate migration, creates stress and anxiety, impacting mental health, and it can undermine the delivery of health care itself, disrupting operations and causing evacuations. Climate change has so many aspects where it reaches into our lives and threatens our health in many ways. And those suffering the most from the impacts of climate change are those who have faced health disparities from so many issues across the United States, including in communities of color, American Indian, Alaska Native communities, the Hispanic Latino communities, Black African American communities, AAPI communities, and more. The health sector needs to lead by example, and we need an all hands on deck approach. The United States health sector contributes approximately 8.5% of our entire country's greenhouse gas emissions, 8.5%. In terms of global greenhouse gas emissions, the health sector contributes approximately 4.5 to 5%. So it is urgent that the health sector in the United States and globally mobilize to enhance resilience and reduce its carbon impact. So until everyone in the health sector, from nurses to the C-suite and beyond, takes definitive action, the health sector will not be able to make meaningful changes to save the people that they care about and protect the institutions that they work for. So in response, our Office of Climate Change and Health Equity has launched the White House HHS Health Sector Climate Pledge. And we have invited private sector organizations to align with the administration's goals. So far, over 130 organizations representing suppliers, pharmaceutical companies, insurers, health systems, and hospitals have signed on. So between our federal health systems, which are engaged, and the private sector, that's about 15% of the facilities in the United States, which will start to track their progress on decarbonization. We are reinforcing this public-private cooperation through the National Academy of Medicine Climate Collaborative, a public-private effort made of large and influential organizations across the healthcare sector that I'm very pleased to co-chair and work very closely with Dr. Victor Zhao from the National Academy of Medicine, who will be speaking shortly. In the meantime, I want to highlight a few tools and programs that our HHS Office of Climate Change and Health Equity and its sister Office of Environmental Justice have developed, thanks to the Biden-Harris administration's dedication to addressing climate change and health equity. We have launched a catalytic program to help those in the health sector take advantage of billions of dollars available through the Inflation Reduction Act, the IRA, for investments in clean energy, building efficiency, facility resilience, and more. This is through a combination of tax incentives, grants, loans, and technical assistance programming. The office has also launched an Environmental Justice Index, which ranks the cumulative impacts of environmental injustice on health for every census tract. Census tracts are subdivisions of counties for which the census collects statistical data. The Environmental Justice Index ranks each tract on 36 environmental, social, and health factors and groups them into 3 overarching modules and 10 different domains. In addition, we have launched the OT Climate and Health Outlook portal, and I walked in here and saw a copy on your desk. So this is our product, our Climate and Health Outlook. Thank you for including it. This is February, so it's pretty cool. It's pretty cool. And other tools to help forecast and document climate-related threats, including a EMS heat tracker, mapping local emergency responses to heat-related illness. In addition, we are supporting individuals, families, and communities as they manage the challenge presented by climate change, including $3.7 billion in the Low-Income Home Energy Assistance Program, or LIHEAP, which was announced in October. We have broadened research on climate health through the National Institutes of Health Climate Change and Health Initiative Strategic Framework, and provided support to states and cities to protect at-risk populations from climate impacts through initiatives like the CDC's Climate Ready States and Cities initiatives. So all of this is just an example of the things that we're working on, and I just want to again highlight our work with Dr. Zhao, who you'll be hearing from after me, and the National Academy of Medicine Climate Collaborative, and I'm just absolutely so proud to co-chair that initiative. So the good news is that climate solutions are health solutions. Climate solutions are health solutions. They confer immediate benefits to health and health equity. Every dollar invested in prevention, preparation, and resilience is a vital step towards a healthier future. So in closing, despite the heavy toll it has exacted, COVID-19 and the challenges of the last 4 years remind us of a fundamental truth, that we need each other, that our happiness and our very survival depend upon our connections to one another and to our community. And we can do better in this sphere. We must do better. And with all of your help and your new initiative, we will do better. Thank you very much. Thank you.
Thank you, Admiral, for joining us and for those great words of guidance. I'm Hortensia Amaro. I'm one of the faculty at Florida International University who's been involved with this initiative. And I'm here to introduce our colleague, Victor Zhao, who is the president of the National Academy of Medicine and formerly the Institute of Medicine. In addition, he serves as vice chair of the National Research Council. He is Chancellor Emeritus and James B. Duke Professor of Medicine at Duke University and the past president and CEO of the Duke University Health System. I could go on and on about his many achievements and titles and his incredible seminal work in cardiovascular medicine and genetics, but I told Victor I'm going to be brief in my introduction so we can have more of your time. We are really delighted to have him. He's one of the world's preeminent health leaders, and he advises governments, corporations, and universities worldwide. So welcome, Dr. Zhao. We're honored you have joined us to celebrate this FIU Population Health Initiative. As the president of NAM, you oversee critical work done in population health as well as climate. And so we look forward to your comments and your guidance regarding the work and the opportunities ahead. Thank you.
Thank you, Hortensia, and thank you for giving just the right appropriate introduction. It gets very uncomfortable when someone reads my publicist version of my bio, but congratulations. This is wonderful that you're launching such a major initiative, and I'm so glad I have a chance to speak to you today. Now, following Admiral Ravine is not easy. She's given some dynamic discussion of the field, and you're going to hear from me perhaps some repetition, but framing the issue that this indeed is a public health crisis, and an equity crisis. So what can we do about this? This is why your launching of population health is so important. Recognizing that at the end of the day, it's not just climate, it's not just healthcare, but in fact, it's everything, social determinants that's affecting the health population and the response to climate change. So this is it. This is the phase of climate change. When people talk about climate change, I think if you look at news media, et cetera, it's all about environmental changes. It's about a polar bear, which the slab of ice getting smaller, and it's about, of course, the future generations. But my point is, climate change is now, as Dr. Rachel Levine said. It's affecting people in a big way. Now, she's already, in many ways, summarized the impact of climate change. But permit me to just go through some of these issues. Because as you look at climate changes, which are extreme events, but also ongoing events of climate change, air pollution, you name it, it will have an impact on what they call exposure pathways, that is looking at heat stress, air quality, water quality, food security, vector-borne distribution. That can lead to a series of human illnesses, which are shown on the bottom of the slide. Injury and mortality from extreme weather events, well, we see that dramatically on television, and some of you might have experienced it. But also heat-related illness, but respiratory illness, asthma, chronic lung disease, particularly from air pollution, from different pollutants, but also waterborne diseases. Zoonosis is particularly when human-animal interaction in deforestation, bringing it so much closer that result, in fact, in emerging infections. Therefore, one could argue that COVID-19 can be an outcome of some of these issues. And then, of course, vector-borne disease. You already heard both president from UW as well as Emerald Levine, that when your weather changes, the mosquitoes can go further up north and bring their vector-borne diseases, and you're going to see, in fact, these in places they've not seen before. And malnutrition, non-communicable disease, mental health, an issue that's not sufficiently emphasized on the impact of climate change, and of course, many others. Now, just to show you some numbers on the side, I say this is a global health crisis, and of course, a US public health crisis, because the McKinsey report just released said they're expecting 14.5 million deaths from climate-related events by 2050. Right now, we're hovering around 10 million. 5 million from extreme temperatures, air pollution, 5 million, vector-borne disease says 700,000, and the numbers go on and on. I think it's important to recognize, of course, it's also having, as been said, an economic impact. Trillions of dollars economic impact, and of course, as you heard also, in climate refugees and migrants. People being displaced from home, live in poverty. So huge amount of impact. So if I haven't convinced you that it's a public health crisis, well, maybe I'm not doing a good job. But these numbers speak for themselves. But also importantly, equity issue. Globally, low and middle income countries have an outsized effect in these countries. If you look at our countries, the richest 1% emit 2 times the emission of the poorest 50%. And it's not only the emission, it's the impact that if you look at the amount of impact, you look at the third bullet, those who are exposed to climate disasters are 6 times more likely to be affected, 7 more times to die. Why? Because these poor countries do not have the infrastructure, do not have the ability to adapt and mitigate, and hence the effect is much bigger than you can imagine. So I think that you can imagine that a lot of issues, and particularly the population that really lives on directly the indigenous people who live in the land through forestation, agriculture, fishery, and cattle, they are the ones who was greatly affected. So I think the impact is not only on climate and health, the impact is much broader in the global equity issue. Because if you look at what happens, you're going to expect increase 122 million in extreme poverty, and none of the SDG goals will be met. Poverty, hunger, gender equality, reducing inequality. The consequences are huge. And so now I make the case is also an equity issue. Rachel Levine said 2030 was the hottest year recorded ever. And what this slide shows you is that there were 28 confirmed climate disaster events in the United States, causing the impact of about $1 billion of loss to the United States. There were drought events, flooding events, severe storm, tropical cyclone, wildfire, and of course winter storm. As she said, there was deaths to about 490 people from extreme weather alone. If you track this frequency of events in the United States from 1980 to 2023, it averages about 8.5 events. But if you track only the last 5 years, it's now 20.4 events. So I don't know what people are living in the sand or have their head in the sand if they say it doesn't happen. It's just weather changing. I think we're clearly seeing climate change as a major event. Now, this slide just shows you the diseases that I've talked about that in terms of asthma, food, vector-borne, is happening everywhere in the United States. Nobody's, in fact, immune from this. In case you think, well, we're just fine, we're not. And back to equity issue. The impact is greatest in the vulnerable population. If you look at the inequities, it's those who actually already face the disparities, economic, socioeconomic issues. The poorest counties cope with unreliable infrastructure, inadequate power supply, lack of transportation, and non-existent or poorly maintained escape routes. Those in vulnerable communities account for the majority of deaths in the United States from hurricanes over the last 30 years. And of course, you have all seen Hurricane Ian and Katrina and many others, where it affected really a lot of particularly vulnerable population. So let me talk a little bit about environmental justice, because they're interrelated. Of course, you can argue not all environmental injustice related to climate, but many are. But so that I can just show you, demonstrate, I think all of us seen, at least for me, what was really vivid was during Katrina, when you look at the destruction in New Orleans, and the hospitals, and people really climbing on the roof of their houses, etc. That was devastating. Black snow, you know this well, right? Everyone know about black snow? Yes, no? Show of hands? Not as many. Oh, well, you know, every winter and spring, sugarcane companies in the glades burn their corn, right? And the cane fields, in order to get rid of the outer leaves. And that creates tremendous pollution that people call black snow. And of course, if you know your communities in Pahokee, about a third of the population live in poverty. Communities are mainly black and Hispanic, and they're the ones who are subject to this, not West Palm Beach. And so 4 times the average of air pollution during this time. Cancer Alley, Louisiana, and 85 miles along the Mississippi River from New Orleans to Baton Rouge, whole concentration of oil refineries and petrochemical plants. And of course, you can imagine the pollution there. And people who live in these areas, depending on the counties, are 50 times to up to 800 times more likely to get cancer. And this is all recorded statistically. So you can imagine the kind of problems. And I can go down Asthma Alley in South Bronx, where the mainly people who live there are mainly African Americans, who are subject to tremendous air pollution because of the industry and asthma, respiratory disease, and of course, you know about Flint, Michigan, and many, many others. So I think I made the case that this is a public health crisis and also an equity crisis. So this is where I'm so proud of the members of the Academy who's here today. I see Hortensia, I see Jean, I see Bill Fager, Martin Cepeda is not here, but you guys are advisors to this major program, and of course, Emerald Levine is a member. So we have come together, our members, to say, you must do something about this. And the thing about what we can do, we recognize that we are a trusted, independent advisor to a nation. That's the basis of our founding in 1863. And also, because Congress and the administration listen to us, but also we are actually the voice for science and the voice for the public as well. We convene people together to find solutions. So we decided we're going to take this on, and after a year and a half of planning, we decided to launch a grand challenge. Our grand challenge is called Climate Change, Human Health, and Equity. It's a partnership, global, but mainly in the United States, as Emerald Levine says, public-private partnership. And it's chaired by the whole Grand Challenge, chaired by Dr. Judith Rodin, who was the previous president of Rockefeller and previous president of the University of Pennsylvania. But you can see, as we said, we have about 200 collaborators across the community's network, roadmap, and others. And the collaboration, as you heard from Emerald Levine, who co-chairs the decarbonization collaborative with me, along with, in fact, many people from public-private industry, including Merck, including AstraZeneca, Medtronic, because as you have known, when she's talked about 8.5% of carbon emission of the healthcare industry, a lot comes from actually the private sector because supply chain, manufacturing, you name it. So we need to come together, as she said, all hands on deck to work on decarbonizing this. Now, this whole grand challenge has 5 strategic objectives. First, communication. The public needs to know this is a public health crisis. And the stories that you hear never mentions health, or at least not sufficiently. And then if the public thinks about this is affecting my health, I think if you think about what are the most highest priority for an average individual, it's health, economy, and security. So therefore, there'll be a lot more support for the idea of supporting climate change mitigation and adaptation. So we are now having public communication, but also educating and communicating the biomedical community. I mean, it's great to see some young people here, but frequently students don't know about this. There's nothing in the curriculum in medical school and nursing school, so we're now working to introduce this into curriculum so that they can be both communicators but also practice the issue of decarbonization. Second, as we talked about, is the entire U.S. health sector. So the U.S. government, Biden administration, Emerald Levine's done a great job in creating pledge. But they can only do so much because there are a lot of private sectors that's not under the umbrella. We happen to be neutral convening, so we can bring a lot more people under this. And we're now launching a movement this year to go beyond the pledge, to get as many organizations under our tent. I hope you join us to say we do believe in the whole issue of climate, decarbonization, and we'll join you in doing this. Third is a roadmap for systems transformation. What I mean by system is that when you think about climate change, well, we're 8.5%, but there's energy, transportation, agriculture, water, many other sectors involved. These sectors all contribute to climate change. But they never look at what they're doing in impact on human health. So sectors are measuring consumption, emission, mitigation, economic impact. Our question is, do you know what you're doing to human health? And importantly, when you make policies, how do you know if your policy while you're reducing carbon emission, is not actually affecting human health. So our idea is to have a systems approach to have all sectors looking at the impact of climate and human health. Research innovation, and of course, importantly, there's so much opportunity for all of you. That's what you're doing in looking at research, the connection between climate and health, the mitigation, many others, and finally, because health inequities. I'm going to spend the rest of my talk on this issue, particularly because it's about population health. So these are our 5 different work streams or programs: communication, roadmap, decarbonization, research innovation, and of course the Climate Community Network, which I'll talk about. Now, when you think about climate and this whole issue, it's very clear that what we're talking about, as you're talking about, is individual and the population itself. This slide is actually very helpful when you look at the center, exposure pathways, top climate drivers, environmental context, health outcomes, but the social behavioral context is absolutely important because it is how people adapt to the climate changes, how people behave and work towards this that can really address the issue. So population health, importantly, of course, is looking at high-risk groups, target prevention and tailored care, and improve affordability and ease the burden, meaning looking at social determinants of health. So if you look at that, we have to ask, who's the vulnerable population? This slide shows you the particularly vulnerable population. They are dependent on biologic, demographic, geographic, socioeconomic, and social-political. But the vulnerable population are usually those who are living in poorer communities who have chronic diseases. Here I've shown you children and older adults, socially vulnerable individuals, indigenous people, right? Indians, Alaskan natives, and of course globally indigenous people, people with chronic disease disability, workers, and women. Globally, women play such an important role in managing families and taking care of even work that they are particularly vulnerable. And of course, pregnant women, breastfeeding, and postpartum individuals. These are all documented as vulnerable population. So we have decided that what we want to do is focus on this population to say, how can we work together with the population and the communities, hence the creation of the Climate Communities Network. What we want to do is work with historically marginalized communities, and you can hear from them say, our voice is never heard. They're rarely engaged in fact, in decisions that impact them. Secondly, of course, we want to create a network that represents those who are disproportionately experience the worst health impacts. The way you approach it is to try to find ways to connect with frontline communities, and particularly not only the voice of the community, but also community-based organizations who are already working with the communities so that we can help them achieve their goals and move forward with solutions. And foster connections, because they can't do this alone. What we want to do is to create a public-private opportunity. Government, foundations, academia, and industry together to say, how can we help you in the communities? So integrate community voices in our research development, plan prioritization, decision-making, mobilize youth. So we have engaged youth to be actually citizen scientists. I'll talk about that a little bit. To actually being able to see and use the photo voice approach of documenting what they see. That together with data is a powerful narrative to speak to policymakers. And then also, of course, innovative methods for data collection, surveillance, as I said, photo voice, and many others. So we want to collect data, want to figure out what are the issues and co-design solutions. So how do we approach this? Well, we work with University of Washington, and they have an environmental climate justice score. This score looks at the impact, the largest impact of county by county of climate. On top of that, we also look at the socioeconomic impact. This score allows us to look at, as you can see in this map, the ones which have highest score, and we want to work with those communities. So by doing this heat map, we have looked at which are the vulnerable populations, and then we open for application for people to come work with us. Of course, we can't work with everybody. So we had 70 applications from 30 plus states, as you can see, throughout the United States. And then we actually went through a rigorous selection process, ended up with 18 such communities. I'll talk about that in a few minutes. So the whole idea is to get the expertise of community leaders, but also to bring together those people who can help what we call strategic partners, as you can see here. Who are they? EPA, HHS, you heard, and foundations. You know, there are many foundations join this, academia, and of course, together we can say, tell us what the issues are and how can we find solutions for each of the communities. So this is our 18 members, if you will, and you note that Florida has 2. And actually they're both in the Dade County in Miami, but these 2 organizations are quite amazing. One is a Dade County Street Response is a relief response organization that works community under extreme crisis, etc. The other one, which is the Clio Institute, is an education advocacy organization. We feel that they can represent the voices of people in that area. And we certainly welcome many other participation. We have brought together strategic partners, as you can see, from public, private, AstraZeneca, from HHS, from EPA, and many others. And our idea is to say, let's look at this thing together, and probably when you look at your population health, you may want to think along those lines. What policy can we help develop to help you address this issue? Having the government people there is really good so they know what are resources available and what kind of policy may be needed. So community-informed federal, state, and local policies. Funding, equitable community-driven investments and innovative funding models. We actually have banks, particularly the philanthropic arm of those being part of this. And also, of course, government funding. You heard from Admiral Levine, the administration have lots of opportunities for you to access funding. Data, representative, context-specific, and actionable. Capacity building, really important, to help to look at what kind of resource needed, and engagement of youth, as I talked about before. So we are committed to co-create opportunities for members and strategic partners to learn, to inform, to exchange information, to look at co-creation, and look at issue of policy, funding, research, and capacity building. So our principle in working this is the following, that there's no one-size-fits-all approach, that every community is important in understanding what their needs are. No longer do we say, we are from Washington, we know better. We work as the power dynamics, as you can imagine, in the partnerships with the communities. We want to have community ownership. And we want to strengthen local capacity, particularly in finding state, local, and federal foundation support. So empower with evidence, build scientific equitable partnership, capacity building, and open tools and data. So I believe that, I hope I've convinced you that this is such an important issue, and the action is in the community. At the Academy, we have a major initiative called Climate Crossroads, which is Academy of Science, Engineering, Medicine together. Just so happens we have our advisory group together today, and as we listen to people from engineering, from different sectors, the common denominator they said was, we got to get out there to have action toward communities. So I'm very glad to tell you about our program. I'm excited about your population health program. I look forward to working with you, and so many of my members are part of this anyway, so find ways to work together. Thank you very much. we do that. Questions?
Thank you so much for sharing such an impressive background and experience that you have in the climate change. That's really, really exciting. Can you tell me a little bit about Grand Challenge? Yes, when it will start. It's a really interesting project that you're working on.
Yeah, the Grand Challenge is a concept that we have, particularly since Hortensia told us we used to be an institute, and what is it now, Hortensia, over 8 years ago, we became National Care Medicine, and we thought with membership that we should take on big, bold ideas, not just do report by report. And as we look at bold ideas, it's very obvious that climate is the one that we should be doing. So the Grand Challenge is the idea of bold, audacious goal and get out of our comfort zone to include everybody, public, private. Traditionally, Canada is a little bit more cautious about working with industry, but I think industry is a big part of the solution, and therefore we need to work with them. Traditionally, we don't work that closely with government. We advise them. We do reports. And as you can see, Emerald Levine. Just in time. So we work with government in a big way.
May I have your attention, please? May I have your attention, please? There has been a fire emergency.
Have an intermission.
reported in the building.
So when I mention the Population Health Initiative, I'm just going to refer to it as a PHI in order to get through it quickly because I only have a very short time up here. And as I do that, I just want to indicate to you that we've had very strong support from many quarters for the work that we're doing today. And actually, I think Eliseo Perestable, who's going to be speaking later on in this program, who comes from NIH, has been very powerful in supporting the roots of our program too, and he actually has been initially important in getting some of our programs funded that are going to be part of this initiative. So I think we'll hear from him as to what his ideas are a little bit later on. So I'll briefly describe the motivation and purpose for developing the Population Health Initiative. The idea was developed a few years ago by a faculty group who are also American Academy of Medicine, National Academy of Medicine members, and they're in attendance today. You've heard from them already. And we're talking about Jeannie Miranda and Hortensia Amaro and myself, of course. We're supported in this work by Vice President for Research and Economic Development and Dean of the Graduate School, Dr. Andres Gil, and to execute the development process itself, Dr. Iris Aguilar was recruited to FIU from California as Administrative Director. FIU is a mature research institution. I think we have to understand where we are in the arc of development. And they're ready to address issues affecting population health in partnership with regional, public, and private sector stakeholders. The 4 priority areas we selected that form the thematic core of the PHI research program are shown here. I see they're very consistent with what was put up previously by Dr. Zhao. The PHI focuses on inter-organization networking for improving health, working to shape decisions, policies, and practices among stakeholders and communities toward optimal health, and preventing or ameliorating health threats in populations. This requires intersecting with health and non-health organizations in the design of strategic solutions. I'm just trying to focus on the fact that we're really trying to look at the primary levels to have the biggest impact we can in the kind of changes that we bring about. FIU had developed significant programs of outreach to communities and public and private stakeholders in the past. An exemplary model is the FIU Institute on Environment, which is interdisciplinary and well-connected regionally and nationally, and you're going to hear more about that after my presentation. Our medical school has decades of experience in provision of direct community services, as well as our social work and nursing units, and our public health school has recently initiated a global health research unit with distinguished scholars. Elevating the coordination and scaling of these projects and the goal of increasing their policy impact is the operational goal of PHI. We will strengthen academic units with high caliber technical and material support using pilot study funding, and we will intensely monitor, support students and junior faculty members pursuing careers in population health. It's very important for us to see people through to success, and that these things are long range. A commitment is long range. Projects have to be long range from the standpoint of understanding that we want to work through these issues as policy focused and is program focused to end results that are evaluated. We examined PHI research programs at other national universities. We selected the University of Washington as a premier example of a working model for regional, national, and international population health research. We were very fortunate to receive a positive reception to our request for a formal partnership with the University of Washington and cooperative projects that have already begun. We are fostering interdisciplinary research leadership at FIU using the University of Washington approach of having faculty fellows as team leaders in the major participating disciplines and creating interdisciplinary research partnerships and assisting them to acquire financial support. Our first generation of faculty fellows are outstanding scholars, and we haven't actually pointed to all of them yet. We have 4 of them here today. Our first generation includes, actually 5 of them, Noel Barengo, Rajiv Chabari, Attila Herendlendi, Mariana Sanchez, and Rita Tutonico, who you're going to hear more from Rita in just a moment, because she's going to be running the panel program right after this. So currently we're identifying outstanding candidates for scientific director using an ongoing national search. So if you have any suggestions of people that you're aware of, we'd certainly like to get them. The next step is selecting a formidable stakeholder advisory group that reflects essential government and private sector entities that are confronting the kinds of issues that the PHI, we believe, will be attempting to target on themselves. Most certainly the future will not be what we expect it to be because, you know, all things go astray, and no matter how you plan, it's never quite the way you thought it was going to be. But what is certain, FIU has a distinguished group of scholars that can provide world-class research, analysis, and material support to address the challenges ahead. FIU has an established culture and real-world relevance in the way it approaches the world and is a cornerstone. It's a cornerstone for its academic progress. And I can tell you, I've been at many universities, distinguished universities in the past. I am so impressed by the real-world commitment for its students to prepare them to go out and make real change and to go out and get good jobs too, but go out and make change and do it realistically in the real world. So I think many students complain about the lack of that connectedness to the real world when they come out of college. I think FIU does a premier job of this in preparing its students at all levels. Now, I'm going to end this presentation, and I'd like now we're going to have a transition the program to the panel program. And so I'd like to introduce Rita Tutonico again, because she's the Dean of Arts and Sciences and Education at FIU, and she's been a major resource in the development of PHI. I can't thank her enough. She's been so helpful for us because she has such a deep background and she has such a key position, and as a consequence, it's been enormously rewarding working with her. So at this point in time, I will turn it over to her and give her an opportunity to develop the panel.
My panelists. So thank you and welcome. I am Rita Tutonico. I'm actually Associate Dean of Research for the College of Arts and Sciences, and I'm also the PHI Fellow. I also want to recognize Trudy Gillard, who's one of the other fellows that wasn't mentioned just in the previous introduction. So I'm really delighted that we have this panel here. I'm also going to be representing the Institute of Environment at FIU, since my background is also in sustainability science, food security, et cetera. So kind of make that bridge with the population health. So I'd like to invite my 2 panelists to come up, and we've asked them to answer a couple of questions, and then I'm going to try to make this more of a dialogue with you and some of our distinguished audience guests. So first I have, on my right, Ali Muqdad, who is the Chief Strategy Officer of the Population Health Initiative and the Institute for Health Metrics and Evaluation at University of Washington, and has been really so helpful today, giving us a lot of his insights, and so he's going to share some of that with you as well. And then Jose Pagan, who I've not got a chance to really talk with that much today, who is a chair and professor of the Department of Public Health Policy and Management at NYU. Go New York. And so I've asked them a couple of briefing questions I wanted them to start with, and then if there's time, I'll add some of my perspective from the Miami and Florida International University perspective. So the first question was really to get their insights on what are some of the lessons they've learned from how do you do these partnerships with regional and local communities and the different stakeholders in your regions on these issues of climate and population health. And so like a few minutes each, and then we will go to the second question.
So for us at UW, we realized that many of the problems that we want to solve cannot be done by one group. And we started going around within the university and then telling everybody that you have a big role to play here. That was very important for us. Everybody has to see themselves as part of this solving of this issue. So we brought people together in order to tackle one issue. It energized our community. So for the first time, the School of Art and Sciences, for example, found like, oh, I have a same role to play here as the School of Medicine, which is very big at the University of Washington. And then what helped us is our communities. So every time we went to a community, they're telling us, you send somebody to talk to me about this, then another guy comes and you guys don't talk to each other at the university. A university like ours, and Florida as well, you build the centers of excellence. I'm not going to call them silos. Center of excellence, they don't talk to each other. And even sometimes within, they don't talk to each other. That energized our community. And from our experience, early on when I started going around talking to deans, to chairs, to invite them to be part of the Population Health Initiative, there was some resistance. Why? What are you doing? Why are you creating another layer? School of Public Health will tell me, oh, we're doing this already. What are you here bringing to it? Now we are at a stage 7 years later, almost 8 years later. What we hear the complaint is we create a council within the university from every college in order to advise us internally what we need to do. Now when I get an email complaining is why I'm not on your council. And the president, I'm like, why I'm not on your council? We're the #1 department of biostatistics in the world, and we're not on your council. So that's what it took. It energized our community, it energized our student, it addressed the issues that our student coming to us right now, they want to do comprehensive work. They're not interested in one discipline. And yes, they want to be the best engineer, but they want to know how engineering will solve the problems in their own community. So that's how we did it, built it from the bottom up. It energized our community. It wasn't easy early on, but everybody now sees the value of it because when we apply for a grant, we're multidisciplinary and we have an edge.
Thank you. So I play two roles in New York. One is I work at NYU, but another one is I also chair the board for the hospital system in the city, which is a lot of work, and it means also that basically we're talking about basically a safety net system in the city. So 11 hospitals, we have 6 long-term care facilities, 80 clinics plus. It's a huge system, 45,000 employees. So you basically get to see how community organizations and the healthcare sector work together with universities, not only NYU, but also how NYU works with them. And one of the things that I've learned by playing that role is that when the health systems is facing challenges, so for example, connected to climate change, it could be, weather-related events. Typically, if everything is related to like a hurricane, a storm of some sort that hits New York City, and we need to figure out how to, solve the problem or solve some issues connected to it. The universities can play a large role helping in terms of research, in terms of resources, students, anything that they can deploy. So it is critical to have that connection between the community organizations and in this case, a safety net health system and the universities to make things happen. So I'll give you a very concrete example on this that expands beyond those two organizations, which is the problem of cardiovascular disease, hypertension in New York City, and how you bring together different partners to the table. If the health system wanted to, this is a safety net system, so it has money, but it doesn't have a lot of money. And every private system or nonprofit is, every major system is doing their own thing, looking at their own people. We care for everyone, immigrants, the undocumented, people that cannot pay. So for example, to address issues of cardiovascular disease, we have been able to do it by building partnerships. So we bring together, for example, a major pharmaceutical company, Novartis, to help us, Microsoft to help us with technical assistance and so on. Then the university brings students and researchers to basically look at data in the city and say, these are the pockets where social determinants are an issue where there's health-related social needs. And these are the neighborhoods in which we should intervene to do something. If the health system wanted to do that, they don't have the resources to do it. And they need the university to do it. And I think you would find something similar in basically every other community in the US, that you need a place, you need an initiative. You have it here. You need an initiative to make that happen.
And if I can add a couple of comments from the Miami example, when we started working, we started this Resilient Miami initiative, and it was working with the resilience officers in Miami-Dade County, and Miami Beach, and Miami. And they got together to figure out what we thought were the major challenges that the communities were worried about. And we were thinking, they're worried about sea level rise, they're worried about flooding in their homes, they're worried about all these things that climate change is going to bring, malaria, infectious diseases. And when they did these community charrettes, what they really found out was that they're really worried about heat. And heat, there's so many places that people rent, they don't even have air conditioning. It's not even included. And there was all of these things. So heat was the major factor that the community was really worried about. And so it really led to this whole heat action plan from the mayors and to actually come up with. And so it really made us realize that we always thought we would co-produce the solutions, but working with the communities to co-produce the questions is really, really critical. And so I think that was a really big lessons learned that at least I take from some of our experiences that we want to incorporate going forward. So I think that was really, I think Dr. Zhao kind of set that up for us as well, that's really critical. Okay, the other thing that we want to get your expertise on and experience is, are there any unanswered questions that, as we launch this initiative, we want to, be leading edge, right? And we want to be answering questions that have not need to be answered that you haven't addressed yet in your initiatives. And so if there's anything that you recommend as we launch this initiative that would be really regionally and globally useful in this area.
So there is a lot to do. I mean, even if you pick one of them, climate, there is so much to do. My advice would be, and that's what we did at UW, we didn't want to be a mile long and an inch deep. We wanted to focus on certain things. And it's an initiative of 25 years, so we'll have time to tackle the next one. So we're not gonna. And the way to do it is to set a priority within the university based on why us, why the University of Washington is better positioned to tackle this problem. And that's how we built it, around what we can do. So in all our thinking, we're telling our faculty when we decided what we want to tackle, what's the problem? Why UW? Why is UW better than NYU or Florida in order to tackle that problem? And the most important part, we want to be an outcome oriented. What is success? Tell me, if we do it at the University of Washington, what will happen? And then unless you answer these three questions, we're not going to be able to move forward. And we will not be able to advance this initiative within the university. So that was very important. The second thing that was important as well is what's in it for me. I mean, I'm being straightforward here. If you go and talk to different deans, different professors, what's in it for them? It's population health. Is it School of Public Health? Am I going to do the job of somebody else? And if I succeed, that person is going to take the credit and not me? So what's in it for me? And we had to address this. So I'm going to end on, when I started going around, when I was appointed to take this role, I met with the Dean of Art and Sciences at the University of Washington. It's the largest school in terms of students. It's not the largest in terms of money. School of Medicine is 80% of our budget. The guy looks at me, I mean, a very good friend, said, Ali, when I look at this university, I see a School of Medicine and a football team. I don't see myself. I mean, told me, why are you coming to me for population health? What's my role here? And of course, I'm prepared. I talked about anthropology, I talked about sociology and what they need to do. Today, in funding from the population health, you heard our president, we gave money to faculty. Guess who's the number one recipient in our university? We have nursing, we have pharmacy, social work, environment, built environment. I mean, I can go on. Guess who's the number one recipient in our university? Art and sciences. They felt they have a role to play. Their art is very important for our physicians, for our patient, for mental health. and then we encourage them. And now they're applying for grants as much as the School of Public Health and School of Medicine. So we had to build that from the ground up. We have to let everybody feel they own it and they are part of the success.
So that's a hard one to follow, but I'll follow it.
He is hard to follow.
which is you'll see the connection in a second. But you know, when I think about population health, and I was trained in a program connected to population health back in the day in the early 2000s, and people would debate the definition of population health, and we're still debating the definition of population health. So the definition at that point was, and it's probably still there is now, is like David Kindick's. You know, it's the health of a group of people and variation in between. So then you have the other group doing population health management in health systems. I care about the patients I serve, and that's basically it. And I may have a registry and all these tools to manage cases and so on. So the trend that I'm seeing is that, because of the hospital work I do, is that the healthcare side is switching towards more population health, the way you and I think about population health and you're thinking about population health. So how do you then take advantage of that opportunity and get into that? I think that's the challenge. And the biggest challenge that I see there is connected to data. So I'm now being asked to manage a population, and I know weather matters. I know access to addressing health-related social needs matters. But if I'm a health system, I keep my data to myself. If I'm a payer, I keep the data to myself. So how do you create an environment where data is shared so that somebody took out the 4 things that were here? I was going to point out. So that you can address these 4 issues, connecting it with data. The best example that I can think on this, quick example, is something that I've been spending a lot of time on lately, which is this data from NIH called All of Us. They said, we're going to collect data on 1 million people, all sorts of data. I don't even know that they know exactly what they're collecting. It's just a lot of data from surveys, EHRs, mobility data, and so on. And you know where the person lives and all of that. And there are like 9,000 projects now of people working on that. If you go to our webpage, you'll see that there's 9,000 different projects. People analyzing temperature change and how that is impacting health. And having that platform, being able to say, having a platform where you connect the data and then having the space, not the physical space, but the sort of like the ability to connect all of this, will allow faculty at the university to flourish.
That's a big challenge in a lot of fields,
Yeah.
And
Yeah.
actually we have another initiative on open scholarship, and I think that's another question about how do you make those accessible to the people who need them, and that, as we talked about before, if no one reads the paper, it didn't happen, right? So how do you get that data so it's actually accessible?
Yeah.
So we wanted to have, am I doing good on time? We wanted to have some interaction with the audience, since we have such a wealth of expertise here, and we really have a lot of people who can contribute to this discussion. So I want to see if there's any burning questions, and then if no one raised their hand, I might call on a few people. So does anyone you have a question?
I do.
Okay.
So how long did it take UW to bring those deans together and the faculty together? This is important to me right now.
The clock is ticking.
A very good question. And since I have the president here and I have you, what we did, the provost at that time put some money in order to make it happen faster. And the way we did put money is for joint hire towards retirement. We gave $150 for 4 years towards retirement. And one condition, it's a joint hire from different colleges to work on population health. Then we gave what we call grand challenges for innovative idea, that you put this idea as a proof of concept. You want to apply for an R01 or another grant. You need some money, $50,000, to show that you can do it. And the president is here. To our surprise, and we're a university struggle, any university with funding, and the provost is telling everybody no, no. And then suddenly, when we put like 1.5 million for grants, we had about 6 million in matching from the they had a skin in the game. So we said, if you have matching funds, we'll score you higher. So we're giving you 50,000, and there are 2 or 3 colleges, they put 50, because they wanted to rank and get our 50. So we felt that there is even a little money that we put forward, there was an incentive to bring them together and work together. It took us the first 2 years to get there and make sure that people can work together. And we positioned ourselves, which is the most important, we're in the service business. I'm here to help you. If you have an idea, I'll help you. If you have an idea you want to incubate it in a safe place, I'll incubate it in the population health, then I'll give it to you later on. When people saw us not a threat, and we're not competing for funds, we're not taking away from you, we're helping you to get more money, then everybody said, okay, I want to work with these guys. COVID-19, every problem was in the university, to funding to work with the community in recovery, in response. Everybody came to the population health. What are you doing about this? I have this idea. Will you give me money to do it?
Thank you. Any other questions? Bernie? Yes, Rajiv?
Hi, Ali. Just wanted to learn about the initial projects that PHI at the UW first started supporting, because we all know about the different stages of evidence and intervention, starting from individual to interpersonal to society and community, etc. And going straight to the policy level often has got its challenges. At the university level, that faculty are used to having more kind of perhaps individual level data collection, and those tend to be funded more often, such as within the NIH. And then some disease areas might be important that you collect those information to inform the policy development. And that also is important for creating traction at the policy level. Without data, you don't have much traction. So, I mean, I'm just curious, when you started this classic tussle between, what are the kinds of projects PHI at UW funded?
So we created a council internally, and we have a board outsider for advisory for the population health initiative. The council is a representative from every college, and we have 3 campuses, Seattle and Basel and Tacoma. So we had representation from everybody in. And that council decided on what we'll put forward to get as a grand challenge, proof of concept. And we created a scoring because, we didn't want to be blamed. Why didn't you give me money? Why gave you her the money? So we created a scoring. The scoring was this idea can get more money funding. So you're proving a concept to apply for something else. So what's next for you? 1, you have to work with a community, and you get more if it's a local community. So for example, some of the application was Somali community, it was us, but working with Somalis, and they're back in Somalia as well, like local to global, global to local. And then if you have students working with you, if you put more money yourself, how many collaborators you have with you. And we were very strategic what to pick the first wave of them. And I told before in the meeting, I get in trouble when I give an example. He's courageous, he gave one example, because at UW everybody said, what about me? I also did a good job too. So to give you an example, one of our applicants early on was for suicide prevention. So we have an injury prevention in the School of Medicine. And they applied for a grant, and they said, we see patients coming in that they are considering suicide. We want to work with their family to move away the stuff that they can use to commit suicide. But many people don't come to the university, so we want to work with the community in case somebody is there want to commit suicide to prevent that. And they worked the nursing, School of Public Health, School of Medicine, and social work. So the grant came from us, $50,000. These guys went and got $7 million from CDC during the previous administration for gun control. So for us, we felt we invest in something that we feel there is a missing science behind it, involves the community, and take a topic, suicide prevention, but take it to the community as well, not one individual at a time.
That's a good segue to something I wanted to ask about, and I might ask Megan Bland, who's from the National Conference on State Legislators, about, we were talking about partnerships, right? We want to partner with universities, communities, and government and agencies. And so I don't know if we were talking before, if you have any ideas or suggestions about how we make these partnerships work, and anything from your perspective as in the state legislator office.
Yeah, one of my questions is going to be like, how have you guys gone out to community leadership, local policymakers, state policymakers? You know, a lot of them are desperate for funding, and a lot of them lack the technical capacity. And so one of our roles at NCSL is to provide information to them. We get regular information requests. I'm currently doing one on coral reefs, quite interesting. But, you know, how are you communicating with these individuals so that they can make changes in their own community when they don't necessarily have the funding or the grants or the information or the expertise at hand?
Very, very good question. So I have to admit the Seattle campus is less engaged with community than the Tacoma and Basel. And then when we started doing this, we wanted community partners. And then we reached out to different counties. So we have a farming, you know, if you go east of Washington, we have a big farming community. We have Hispanic migrants workers who do a lot of the work. And then we went to the community and said, from you, what would you like us as the University of Washington to do? What kind of project? So we did a listening tour early on. And some of what they told us sometimes was really harsh. Showed a lot of weaknesses at the university. I mean, King County, where we are, I went and met, Jeff Dushin. All of you know Jeff. And Jeff said, Ali, you graduate an epidemiologist and he comes here or she comes here, doesn't know anything about public health. How can I work with you? How can I create that in order to make it for me? So we had to listen. And then we have at UW, we have a lot of students that we give them funding if they're the first generation. And then they come to UW. We used our students to get to their community, and we used the student, I use this a bad word, we engaged the students to work with us in these communities. So we felt if you are Native American and we're reaching a tribe, we want one Native American student to be involved in this because we want you to go back to your community and help your community. So listened a lot to communities. I found out stuff that I didn't know. For example, Clallam County, I don't know if those of you that in Washington, when we went to talk to them about population health, all what they were talking about is the drug issue. Like the police force, everybody was like just saving people from dying from overdose. And we're talking about others, and I said, no, it's a drug. How could you help me with this problem?
One approach that I've seen work is, and this may sound silly at first, but it does work, is like you set up a meeting every week at the same time or every quarter, but consistency on how often you meet. So for example, I've seen this in the Bronx where different partners get together to address community problems, but they all have one place to go, and then they interact with each other in a consistent fashion. And I've seen this also with projects, like I used to work at a place called the New York Academy of Medicine, and it's a convening organization. And I think universities play that role too. And we would get together to talk about a given topic. Everybody comes to a table, they learn from each other. So that was the way that I would learn, for example, if you were doing, let's say that there was one in primary care in general or social determinants, then you would basically know what every partner is doing, get updates from the state, but you need somebody to facilitate that, to make that happen. And that tends to work.
One thing, when you come to such a meeting and people talking about population health and everybody brings stuff, you look what we missed, what we didn't talk. And I hate to bring it up. I grew up in Lebanon, so I'm an Arab American. I grew up in a very poor farming community. And I want to be brief on the story. The way we store meat, because we didn't have refrigerators and we can't afford to buy meat or olive oil, we raise a lamb or two depending on the size of the family, and then you cook the meat in the fat of the lamb, you scoop it and you cook with it. That's our way to survive as farmers. It's very expensive, so you afford 1 or 2 lamb to do it. In 2010, I go to Lebanon, and then everybody in my village had 6 or 7 lamb, which is unusual. And I was like, what's happening? Asked my uncle. Said, Syria. There was a drought in Syria, North Syria, and they had to sell all their cattle. They couldn't feed it. Prices were dirt cheap. 2010 summer, March 2011, Assad controlled the country because he had food sufficient people didn't die from hunger. Then there was hunger in Syria. There was a revolution in Syria. So the climate caused, it's not here, I'm an Arab, I'm a neighbor of Syria. The war started in Syria. 1 million refugees in Lebanon, 1 million in Jordan, 1 million in Turkey, many people trying to go to Europe. ISIS, America has a presence military. War could be a fact that come after shortage of water, food insecurity. People are gonna go to the street and say, where is my food? So this is something very important for all of us. I hate to be the Arab guy who talks about food, but it's a reality.
Well, you brought up we've been talking a lot about our universities as resources for our communities regionally, locally. And I think we have a colleague from the World Bank. Am I allowed to point to you? Yeah, so thank you. Tamara Rabi, is that correct? And so I think as we think about this, we are also trying to be a resource globally. So I don't know if you had any comments or you might like to convey.
So first of all, thank you
for
so
joining
much.
us, by the way.
Well, thank you so much for the invite, and I was delighted to hear a lot of the messages that came out today, and particularly with the focus on people. I think that everything that has been said today is really putting people at the center of climate action. And given that I'm from the World Bank and financing, this is what we need to be able to focus our attention on. This is, I guess, my first point. The second point, perhaps to underline, and I'm going to pose a question also to the panelists in just a moment, is the fact that the links are well established. We know the links between climate exposures and health risks. But what we perhaps are not well versed on enough as of yet are the solutions to be able to deal with the climate crisis. We know some of those solutions, and we know that some of those solutions as they relate to adaptation, resilience, and mitigation. But it's going to be extremely important if we were to move forward in identifying what is going to bring more value for money. If I'm investing in scaling up climate action, which solutions I would need to prioritize at a country level to be able to bring this. So it brings me, I guess, to the first question to the panelists. How do you see academia working in the space of creating global public knowledge and public goods on issues that relate not just to the health side of things, but the economics? I was very happy to see that you had health economics as part of the population health initiative that you have there. There you go on the screen. So it's going to be extremely important for us to perhaps define the research agenda that we need to be able to bring forward. Solutions has to be one part of that. There's a lot of talk that we have been sort of propagating on the best buys for climate and health. How do we push forward on that? And how do we ensure also, that we're keeping ourselves accountable in what we do in measuring results? I saw on the screen you had the Lancet countdown, monitoring, results. How do we bring academia also in this space and define actually the indicators that would get us really to keep our eyes focused on that? Perhaps just to end on a note, just to say that it is extremely important for us to recognize that the decisions that we're making today are impacting generations to come. So what's in it for me? Yes, very true. But what's in it for the generations to come should be the end goal that we're trying, obviously, to be moving towards. Thank you.
Yeah, thank you for those points. Yeah, I think, do you want to take that, prioritizing solutions and global questions?
So, academia plays a large role in terms of we have expertise, or academia in general have expertise on program evaluation, methods that you have developed that could be implemented and deployed quickly to look at this. So one example may be where there are people that do, for example, computer simulation modeling or anything like that that allows you to especially in low resource environments, to find out, to be able to predict what's going to happen in a given situation, not only in terms of health, but also cost and so on. So they're like different sort of like, my sense is that universities, because they have a lot of different talent, can come in and then have something to contribute at every different level. I sat yesterday on a dissertation from one of our students that was looking at malaria in India, and it was about temperature change and weather patterns and all of that. And it took a problem that is not usually analyzed with a climate, it's analyzed with a climate perspective, but they're thinking about like, how do you make projections 5, 10 years out? And then, so it changes the way that people typically study the problem. And academics then have a role to play in shaping that in terms of like how you were trained and how you have to reshape it to look at the problem at a different problem now. So
Academia has the main, I'm not biased to academia. I spent 20 years at CDC.
Yeah.
Academia has a big role to play here, and let me explain why. And after I gave you the example about the Arab and the war, so I can say other stuff without getting into trouble. During COVID-19, I trained people at CDC, my age, that are in a leading position right now. They were handling COVID. They'll call me and say, Ali, I can't say it, you can say it. We had WHO people calling us and say, I can't say it, you can say it. I had ministers of health telling me, you can say it. You can do an interview on Al Jazeera and say it, and I can follow up. So university have a role to play. I'm not elected. I'm not depending on the funding of a country as a WHO. I have to be savvy politically, of course, and not damage my university. But we are in a position to speak up and be a scientific center of excellence. Let science decide. To your question, right now in population health, I need to change my language. You guys do human capital index. We did a human capital index. We're a university. We do education and we do health. School of medicine, School of medicine. And then for me to economy of this country to be good in the future, I need to invest in my working force. 20 to 64, they have to be educated and healthy and not die from tobacco or die from a climate or anything or drug when they are in their prime productivity and the country has invested in them. So we have a big role. And we need to talk about the economy and the implication of the environment and the health and the education on your economy and your development. When I talk to a prime minister right now, I don't talk about health. I don't talk about population. I talk about your economical development.
It's a good note to end on, I think. So I want to join me. I have to wrap up in thanking our panel. They'll be around for more questions. I hope you all are going to stay for the social event after we hear from some closing remarks.
That's going to happen.
You're in charge. You're doing, okay.
Welcome. It is a real pleasure and honor for me to get to introduce Eliseo Perez-Estable. He and I actually started our careers together more years than I think either one of us probably really want to remember at UCSF. And it was a time that Eliseo, disparities research wasn't really respected. Minority health research wasn't particularly respected. And during his time there at UCSF, Eliseo developed really very critical research and understanding the health disparities. Is really a leader in the field. And we were all, he was also you were chief of internal medicine. So he then, it was thrilling when he went to the National Institute of Health to head the institute that was responsible for health of minority populations and health disparities, because we really needed the kind of rigorous science. And he's done so much there. I developed a comprehensive plan that I think has really made a huge impact. He helped develop a framework for disparities research that has been very powerful and influenced the field. And a result that I think is amazing is really through his leadership during the COVID epidemic. I think it's the first time that almost everyone knows minorities did more poorly in many ways. So very, very powerful research. So we're so thankful to have you here, Eliseo.
So I think there's some slides. Yes, thank you. Thank you so much, Jeannie. That was very nice. And it's good to see some old friends and of course, I'm originally from Cuba, so Miami has a central role in my life, although I think FIU opened when I was in medical school, so I didn't go there, but both my sisters worked there, so this is very close to my own interests. So I'm going to just say a few remarks to talk in general about population health. I tried to insert something about climate, so let's, and then we can wrap up and you can enjoy the reception. So start with what we define as population with health disparities, and it starts with the first two bullets primarily. That was the original intent of the legislation in the year 2000. So racial and ethnic minorities and people who are poor. We use less privileged socioeconomic status, low SES, whatever term you like. And we think these are the two most important aspects of this research. They intersect with everything else, and they're fundamental. And when you talk about disparities, this is where it starts. And then you say, okay, no, it doesn't matter. It affects everybody the same. Okay, then you go into the question. It's a scientific approach. The underserved rural residents was a strategic decision made in Congress. I think it was at the time the senator, the majority leader in the Senate was Republican, asked for this, and that was a good thing that it was inserted. There are clear differences for people who are in the rural areas. In 2016, we added sexual and gender minorities, the term NIH uses for LGBTQ+, and we've made a lot of progress in that area. And just last September, people with disabilities were added as a designated population with health disparities. And we see this unifying theme, all social disadvantage that results from being subject to discrimination or racism. That unites all these populations to some extent. And there are then other differences that come from there. In this research, I already said the first point, these are the pillars of disparities. We think that the focus on intersectionality is increasingly important. People don't have one identity. They frequently, first of all, everyone, male, female, non-binary, intersex, on that regards as an identity. Age is different, where you were born, where you live. So there's all this aspect of intersectionality as a conceptual approach to research that is really important when you talk to individuals, when you think about communities. And in that regards, that's come into more focus for us in the last couple of years. And then establish aspirational goals. For the longest time when we did minority health research, if it wasn't just focused on one group, which is what I did initially, Latinos in San Francisco Bay Area, we always compare to whites. The sort of the largest population group, presumably the best outcomes. And so it's been a standard that that's what we use. And we're beginning to try to move completely away from that as much as possible. First of all, whites don't always have, in fact, often don't have the best outcomes, number one. And number two, the majority population, yes, for now, but demographic projections indicate that by 2040, that's unlikely to be the case. So trying to create aspirational goals based on national metrics, and Healthy People 2030, for example, that's just one example. They don't do it for every condition, but I think those are the direction I think the field needs to move. This is work we did with the Institute for Health Metric Evaluation and partnership. Ali was very much involved with this. It's life expectancy by race and ethnicity. Now, it wasn't so groundbreaking in that we kind of already knew this, but it was published for the first time in 2022. The Asian population has the best outcome, and that's very consistent. And all the things that we've done since then, and the CDC has also published that they have the lowest overall mortality. That Asian American, that heterogeneous group of that we call Asian Americans. Latinos are right behind. We used to think we were number one. Now we're number two. And then whites, you see, is in the middle, and then African Americans and Latinos. One of the points here is how poorly American Indians do. I meant African Americans and American Indians. And even though the confidence intervals, the uncertainty intervals are large, the mortality for this population is very poor, and therefore life expectancy actually has gone down. It has gone down slightly for everyone else, and this is where we start with population health. So how long are we living? The NIH director came to, the new NIH director, Monica Bertagnoli, came to our advisory council 2 weeks ago on Friday, February 2nd. And she started off her remarks by talking about decreasing life expectancy in the United States. So I thought that was very remarkable that she did that. So NIH also has had a climate change and health initiative. It is led by the National Institute on Environmental Health Sciences. It's a partnership, it's a collaboration with about 7 institutes involved. I've been involved from the beginning. We're part of the executive committee. This is the area of emphasis. When we talk about underserved populations with health disparities, as I referred to earlier, we're really looking at racial and ethnic minority populations, particularly those of lower socioeconomic status. That's where you see the most disparity. And if you want to look at evidence, look what happened with COVID. When we told everybody to stay home and work from home if you can, and avoid, when at the beginning of the pandemic, who couldn't stay home? Well, the health workers, right? And the construction workers and the service workers and the grocery and those were people of color. So the reason that we lost 2 to 3 years of life expectancy was because people were told, we're going to be protected at home. We, the privileged, probably most people in this room, except if there's a clinician here. And those of you who aren't that privileged, you'll just go out and take a chance, and you probably, many of you are going to die, and they did. It wasn't genetic. It wasn't because they have more diabetes. It wasn't because there's more heart disease. It was structural, and that's very clear now that was the effect. And if we get a climate disaster, the same thing's going to happen. The people who are going to suffer the most are those with the least resources. So I think that's an important component in this initiative. We have, I think the NIH has about $40 million appropriated for this purpose, beginning in last fiscal year. They're now funding these things called P20s or developmental centers. They're expected to last 3 years. Our plan, I should say, is to have then centers of excellence, larger ones. NMHD did fund one on our own budget last year at Drexel because it did focus somewhat on Latin America, and I was interested in seeing something that went on the global side that focused on Latin America. Not sure. Yeah, this has different maps. So this is the SEAL initiative, and I want to. The SEAL initiative, some of you are familiar with, was a community engagement alliance against COVID-19, but now we're pivoting it to other problems. We aren't forgetting about COVID-19, but we're pivoting it to more preventive of chronic disease, social determinants of health. We're in 21 areas, 21 teams across the country. It was targeted to areas that were disproportionately burdened by COVID initially and had a large racial and ethnic minority populations. Because this is in partnership with National Heart, Lung, and Blood Institute and NIMHD, and NHLBI has 10 times our budget, we're able to do more together in that regards. And Gary Gibbons we're closely aligned on this perspective of community engagement. There have been now, you can't see these very well, but we have maternal health. There's an issue on climate change. Climate health has been established that are founded on the principles of community engagement. So you start by listening, finding out what the issues are, and working with the populations. The climate groups are in California and one in Alaska, just so you're aware. And Florida has a very active SEAL team, of which I think FIU is involved. This is another dimension of populational health. This is Washington, D.C., and this is Washington, D.C., but segmented by the residential segregation and the diseases we see with Washington, D.C. in the 21st century. So many of you have heard of the term redlining or know what the term redlining was. It was a time when banks decided that they weren't going to loan money to people who lived in areas that were higher risk. And of course, people who lived in those areas in most urban centers, particularly in the eastern half of the United States, were black or Latino. Latinos come in later. And in the 1930s, under the administration at the time, the New Deal, well, all progressive stuff was going on, redlining was implemented. So when the economic boom started after World War II, what happened was everybody got good loans, cheap loans, if you were white and lived in certain parts of town. And if you were black and lived in a part of town that was poorly rated, and that's not in this slide, you didn't get the loan. And what would happen was that, like I like to use the term, well, it's like you're playing Monopoly, and you have some of the people who are going to play. You say, no, you can't play yet. You wait an hour, and then by the time they start playing, you got a hotel, you got 6 properties, and you start playing. You're like paying everybody money as you go around the block. And that's exactly what what happened here. And we're paying the consequences today. Here's another example of the work we did with IHME. This is not, you haven't seen this yet, I think. It's not published yet. We're almost ready to submit it. It's maternal mortality by county in the US. And the red spots are the highest rates. So what this does in a population health perspective, if you can zero in on a smaller area, you can then get your local areas, is say, where do we need to really intervene on this problem that has gotten everybody's attention? It's embarrassing. The United States, doesn't do well on many population metrics globally, but this one is particularly bad. And you see it's in the Southeast. It's in the Mississippi Delta, what's going on in Southeast Georgia. There are other areas to worry about, but this is where it is, and it's primarily African American and American Indian women, but also all minority groups have higher maternal mortality rates. Now, we also did this analysis with Tom Leveist and Daryl Gaskin. They had done this work about a decade ago, but it was published in some obscure place that I never heard of. When I came to NIH, somebody said, oh, yeah, the economic burden. I go, what was that about? So eventually I said, well, let's redo it. And this paper was in JAMA last year. So essentially the message is, on the economic side, that the cost of disparities by race and ethnicity in the United States is estimated to be $450 billion per year. And that's in 2018, before COVID. Now, take 10% of that and reinvest it in trying to mitigate that. That's the NIH budget. We're not doing that with the NIH budget. That's the NIH budget. And look at the loss we get. This is an economic argument that to try and say, well, if we invest in diminishing these health differences, not eliminate them, I just want to reduce them, maybe we can actually get return on investment, and people will actually then be more productive, and we won't have economic loss. And we do it by college education, which is clearly now the difference in health. If you get a degree, not if you just go to college, but if you actually get a college degree, your health is better across the board. Of course, minorities get less benefit from getting a college degree compared to whites, but they still get a big benefit of overall on health. So this is, I think, an argument on population health. Lots been discussed about community engagement. I think that this is COVID has brought this to the forefront again. One of the reasons was SEAL, the RADx for Underserved Population Initiative also brought it to the forefront. To really, you can't get change in some things unless you do community engagement, unless you have a presence in the community. And it's not come in, do the research, and then 5 years later you leave. It's you're there, and it's sustainable. They know you're there. They know they can trust you. And you also develop this trusting relationship with them, and you listen. I think it's still a dynamic, and it varies by community. It's not one, it's different to work with Navajo Nation than it is to work in the Bronx or to work in the District of Columbia or in San Francisco. So I think everyone has to find how they do this, but it's really important. And it's sustainability, partnership, trust are really the important words. Jeannie referred to our research framework, which was developed by staff, actually, at NIMHD, inspired by work I had done at NIA when I was on their council. But it really just tries to capture the complexity of what we do. It's not comprehensive or causal. We don't have any arrows here. If you asked me to put an arrow, it would go from right to left probably more than from left to right. But there are components everywhere, including biological, individual issues, behavioral, the physical built environment, the social cultural environment, so how people interact and communicate, cohesion, and then of course, being a former primary care doctor myself, I think the healthcare system is critical. When you have 50% of people over the age of 50 having more than one chronic disease, and that's a vulnerability that exists. And how do you prevent that? Of course, relates back to the community. But once you have it, we can do a lot to prevent people from getting worse or developing more complications. We worked a lot on measures, and this is still ongoing task. So the Phoenix Toolkit exists in the NIH website. We've vetted structural social determinants of health protocols. There was a new set of measures that we vetted in December of 2022. And it includes all the individual metrics, and we're trying to reconcile whatever differences exist. And we're moving in the direction of telling our grantees, okay, here's a core group of measures, and we want you to use these. We require you to use this, or maybe we want you to use them, and if you use them, maybe we'll be able to store your data in an open data source, because there are no repositories of social determinants of health at NIH at this time, and that's something we're discussing. So, what can science do? Be an engine for promoting diversity. We're stuck. Only 14% of medical school graduates are from underrepresented racial and ethnic groups. And only 14% of PhD, newly minted PhDs in STEM disciplines, including the social sciences, in the US are from underrepresented groups. We make up about 35%, 33% of the US population. There's a huge gap. We're not going to solve it quickly, but the progress has to be accelerated. In an adverse legal environment, and I acknowledge that for all of us, and in some states, you can't even talk about this. So I think these are things to keep in mind. Community engagement we've talked about, standardized measurement, really emphasize that. Big data is really important for population health. And the data science world just doesn't really understand these issues. And so we have to infiltrate, we have to create our own circles of data science on issues related to disparities and begin to address this. And all of these things go together, and then implement what we know, because we know how to treat diabetes, for example, and I think a great example of population health is, okay, you look at your population, maybe just go to the last slide, define your catchment area. So if you're in FIU, I assume you're going to say Dade County, maybe the adjoining counties are included, I'm not sure, or maybe all of South Florida. And then you know what and learn what it looks like, where the people who live there, what are the characteristics, and then you go to the health characteristics or economic characteristics. Consider the physical space and environment. Nowadays, we have all these geospatial tools. You can find out when people live in a certain area, how far are they from a full-service grocery store? What are the green areas that they have, et cetera. Or you can link in temperatures. People were talking about concern about heat, and particularly thinking about South Florida. And I really think we need to reestablish or establish for the first time in decades a strong primary care healthcare system that people can go to, because people get sick and they need to go somewhere to be seen or be evaluated or get their preventive care. So, and of course, care for the most vulnerable. Thank you for your attention and the invitation. No questions, right? Huh? You can come sit down. I didn't know that you wanted me to.
My name is Diana Azam. I'm an assistant professor and director of doctoral programs in the Department of Environmental Health Sciences at the Robert Stemple College of Public Health and Social Work at FIU. One area is to provide individualized treatments to cancer patients that have exhausted standard of care. We do this by testing hundreds of FDA-approved drugs on the tumor sample that we receive from the local hospitals that we work with. And we perform high-throughput functional drug testing, which is basically testing of hundreds of FDA-approved drugs on the tumor sample. Our feasibility studies were done funded by the state of Florida Live Like Bella Pediatric Cancer Initiative in collaboration with Nicholas Children's Hospital generated very promising results. We found that children with advanced cancers that were guided by functional drug testing and genomic profiling have improved survival compared to those patients that did not go through our functional drug testing and genomics. Ideally, we want to provide individualized treatments for patients that have newly diagnosed cancers, so we avoid the toxic, trial and error of drugs. But in order for us to get to that point, I believe we need to generate data from large-scale clinical trials that will prove that drug testing correlates with improved outcome. And so hopefully in the future, this would be something we could use upfront for patients with newly diagnosed cancers.
As we launch our Population Health Initiative, it is an honor to introduce FIU's sixth president, Dr. Kenneth Jessel.
Thank you so much, Lydia, and thank you all for being here today. What a remarkable afternoon. I don't want to be up here following all of the great speakers that we had. And so I've been playing around with my notes because, I'm enlightened in many ways, I'm discouraged in many ways, but I'm hopeful in very, very many ways. It's been truly amazing. Let's give another round of applause to our presenters and our panelists for all that they've done today. As we wrap up this session and the discussion, it is very clear to me, and I hope all of you, that we have an enormous responsibility in determining the future of our planet and the well-being of its inhabitants. And believe me, I think we heard it loud and clearly, we need to take action now. When I was listening to the Admiral talk about Native Alaskans having to choose between foods that cause diabetes or foods that cause cancer, or farm workers literally having to leave their kidneys in the fields because of heat and dehydration associated with temperatures and water. I mean, these are real problems facing society today. It's also clear that we have to do it together. Time and time again today, we heard about the importance of collaboration, working together. It's not about me, it is about us, our future. And I think that the president of University of Washington said, if we want to go fast, do it alone. If we want to go far, do it together. So it has to be very, very collaborative. I will promise you that FIU will be a major player in coming up with these solutions. We have to. We all have to be major players. And as a research university committed to excellence in education through research and collaboration, we do seize every opportunity to lead by example. FIU, as I mentioned earlier today during the luncheon, is just beginning the development of its 2025-2030 strategic plan. And we've had about 5 or 6 town hall meetings so far where we're just getting ideas. They're visioning sessions, they're discussion sessions. And yes, we're going to be focusing on student success and research excellence and engagement with the community. But I'm hopeful that we are going to be doing things in 3 key areas that will help solve these problems and encourage that collaboration that we heard Dr. Makdad talk about at University of Washington, and the collaboration and the joint hires. And as I mentioned earlier, environment and environmental resilience, health and innovation and technology. And everyone that was up here today talked about the importance of these areas. And we heard if we solve the environmental problems, in many ways, we solve the health problems. And I couldn't have been happier when I was looking at Dr. Zhao's slide with the strategic priorities and the different components on there, including communications. I mean, even our communications and journalism programs have an integral part in getting the message out there about the importance of environment, environmental resilience, health, and innovation and technology. For FIU, on the environmental side, we are the state of Florida's University of Distinction in environmental resilience. We're already doing a lot of great things. And resilience is not mutually exclusive to the environment. Making changes to the environment helps us with resilience, not only in terms of the built environment, but the social environment. And we are going to continue to work on solving those problems. We are a world leader in restoring the Everglades. So when we're talking about planting Melaleuca trees to dry it up many, many years ago, never did we realize the importance of the Everglades to the health of the people in South Florida. And now through federal appropriations and state appropriations, we are starting to see those changes that are so important to our physical and mental health, as well as for the Everglades. And climate technology hubs. These are all important things that were already mentioned with our partnership with Miami-Dade County and 40 other partners. That collaboration comes out loud and clear. Our scientists are also seeking to understand how human health is influenced by alterations in the physical world around us, as we heard today. We're doing great research in environmental lead poisoning that is often not even talked about. You just heard Dr. Diana Azam on the video on individualized treatments for cancer patients. And we are very, very excited about the results that will soon be published in the journal Nature Medicine. So great things are going to be happening. And for the last 5 months, I have been wearing the FIU and Baptist Health pineapple pin. This is the collaboration between Baptist Health, a fantastic health organization in South Florida, and FIU, a fantastic educational research institution in South Florida, to create collaborative opportunities in research, in teaching, and in clinical activities. Baptist Health will now be a statutory teaching hospital. The work that we're going to be able to do together in terms of cutting-edge research and cutting-edge clinical applications, keeping doctors in South Florida, where we desperately need them, is going to be truly transformational for our community. And we are very, very happy about that partnership and many, many more to come. We do over $400 million in research, in funding, in resilience research. We've done this over the last decade, and we currently do about $55 million in research investments annually from HHS. So we are truly a major player in the field of health and environment. I am also pleased in this room today, we have 2 great FIU alums, Dr. Henry Rodriguez of the National Cancer Institute, Phyllis Gianelli, Global Policy Lead at Merck, and many, many more, of course. Let's all remember that our collective efforts today will shape a healthy tomorrow for ourselves, our community, and our planet. And again, just hearing the conversation today, I know we are on the right path together. Now, this would not be possible without the important work of our faculty and our students, and very importantly, the support of our federal partners. And now I am very honored and proud to introduce one of our shining stars, not only for FIU, but for the state of Florida and the nation. He is really a global and international thinker, well beyond what most people do, Congresswoman Debbie Wasserman Schultz. So please come up. Thank you for being here.
Thank you. The only thing you left out was outer space.
Well, and you do that too.
Thank you so much, Dr. Jessel. It is so wonderful to be back here at the central address of FIU here in Washington, D.C., and to be able to help you wrap up this incredibly important program. I'm proud to represent Florida's 25th Congressional District, which is now only South Broward, except for a couple of small towns, and some of Plantation and Fort Lauderdale. So although I don't represent Miami-Dade County anymore, I did for many, many years and have FIU campuses across Broward County in my district, and many constituents who travel south to attend FIU on your campuses in Miami-Dade County. And thank you for your continued leadership, for FIU's continued leadership. This is an essential event, an essential topic that shines a bright spotlight on the nexus between climate and health. You are led by someone with unrelenting vision and unyielding support for South Florida, and it's just, there has been, let's say, there has been a little bit of, I'll be charitable, instability in the leadership of some campuses across the country in recent months, and I would say that we have some very clear exceptions in the state of Florida, not in all campuses, but certainly in this one. And we're very fortunate to have FIU led by Dr. Jessel. And thank you, Dr. Perez-Stable, for, I missed most of your presentation, but as someone who has a leadership role at the National Institute on Minority Health and Health Disparities, making the kind of investment in the right institution as you chose to with FIU. Thank you very much for that. And to everyone here today, thank you for devoting the time, because that's really all of our most precious resource to help make sure we can move the needle on population health. Over the years, FIU has been an incredible partner and ally to my office and agenda. I'm proud to remain in your corner, helping drive so many wonderful and forward-thinking initiatives forward. In just the last few years, just to give you an idea of how tightly woven we've been, we worked together to secure funding for a pet cyclotron center, an invaluable tool for monitoring chronic diseases. Most recently, we landed funding for a coastal subsurface water table and saltwater intrusion monitoring system. There'll be a test at the end of my remarks. This is vital to gather data on the impact of sea level rise to better plan, adapt, and understand how to avoid causing damage in coastal construction projects. Their recently launched Population Health Initiative is now another ambitious endeavor, and one that I'm here to wholeheartedly support, as its central mission is so closely related to my own healthcare agenda. Today, healthcare is far more than traditional medicine. Our healthcare system must extend to every facet of our daily lives: housing, nutrition, workforce, transportation, family services, technology. It's just a never-ending list of connections. And now add climate to that list as well, and place it near the top, because our ever-changing environment directly impacts our health in so many ways. And it's not something that is at the top of people's minds. So having such a concentration like you plan to at FIU is really going to help raise the public's perception of the importance and connection between climate and health. It requires us to better think of resilience right along with equity, as our climate is so intertwined with our quality of health. Make no mistake, ozone pollution, for example, spikes hospital stays. It drives up lost days at work and in school. It fuels wildfires, which pushes up asthma and bronchitis rates. The rise in flooding perpetuates exposure to toxins, and deadly storms inflict more human and property damage while also keeping us isolated or without access to care. Changes to our climate threaten our daily livelihood and societal footing, and it'll do the same to our children for generations to come. In this day and age, population and health must include and account for our climate, and it has to be a bedrock approach to how we think of healthcare, especially in South Florida. I always say that to colleagues who aren't from Florida and to just folks generally when we're talking about the impact of global warming, climate change, sea level rise, who aren't from Florida, a lot of other places, those are topics that are talked about as a someday, more likely in the distant future thing, a someday thing. For us, it is a right now thing. A right now thing. I mean, we are having to spend hundreds of millions of dollars elevating our roads and addressing beach erosion and, like I just said, coastal construction and the impact of the climate change on coastal construction. This list goes on because we are, a peninsula. We have the longest, besides California, we have the longest continuous coastline in the continental United States. And I always only half-jokingly say to people, if they're not thinking about the impact of climate change on Florida, they're going to be calling me Debbie Wasserman Schultz, D. Orlando, and that will be coastline if we're not careful. So, I'm kidding, but not really. So we have to make sure in this day and age that population health must include and account for our climate. We have to give voice to the voiceless. And we owe it all to those who remain disproportionately impacted: children, seniors, low-income families, those with underlying health conditions. Central to my own healthcare vision and embedded in so many of my own healthcare priorities are two pillars, both of which take a proactive stance on healthcare and address the whole health of a person. The first is education and awareness, which is absolutely the key to make sure that you keep yourself healthy and well and that you're not dealing with long-term complicated health problems down the road. And the second is prevention. People have to be armed with proper information, instruction, and guidance about their health and their risk factors, so we're all better prepared for challenges that we face. And our care system has to strategically focus on long-term impacts to our health, more focus on prevention rather than treatment as a first option. And as a cancer survivor, breast cancer survivor of 16 years, I've personally and professionally learned of the importance of going beyond the practice of traditional delivery of healthcare. Social determinants of health cannot be an afterthought, and changes in our climate have to be front and center. Our collective role and mission must be to accept this daunting challenge and rise to the occasion, because the precarious health of our delicate planet leaves us no choice. It's not paying much attention to us. It is rolling along, at a breakneck speed, and we're causing it to go faster and faster, and it's on us to decelerate that process and make sure that we think about more than just whether or not we're going to have beach to throw a towel down on top of and lay out in the sun. Because the impact of that global warming and climate change and its results goes much deeper than that. So our differences in Congress and across a very polarized nation often hobble this mission, this necessity. And we have to face every mission, every challenge in unison with a communal response. But we even argue about that. But we shouldn't, because the bottom line is that we're all in this together. And so for this reason, I've embedded these principles in my prevention work on cancer, tobacco, drowning prevention, the environment, and the list goes on for my own personal legislative agenda, because we really have to look at this in a whole and wholesome way. There's no issue that isn't impacted by the effects of climate change and global warming and sea level rise. Even though on the surface, most people probably couldn't. If we did a man or a woman on the street interview, if we walked down the street outside of this space, we would probably be catching a lot of people flat-footed on their answer to how do global warming and climate change, how are they connected to health? Which is why a university is a perfect platform to use to make sure that we can spend resources on helping to educate the public so that we're not constantly in this vicious cycle of fighting over whether or not global warming and climate change and sea level rise is or is not caused by humankind. Who cares? It's happening. It's happening. It doesn't matter if it's humankind or whether it's the natural changes that result from, just the way the climate evolves over millions of years. It's happening, and it's affecting us, and so we have to do something about it. But for some reason, we spend a lot more time pointing fingers and arguing with one another instead of actually trying to address it. So I want to thank all of you, FIU's leadership, especially Dr. Perez-Stable's team at the NIMHD for leading the charge, for example, on minority health and health disparities research. The newly launched Population Health Initiative is so incredibly important. So thank you for leading the way once again. I'm not surprised that FIU would lead the way, and I'll tell you, some of you are old enough or have been around long enough like I have now to remember FIU, and I say this not every time I come, but it's worth repeating. I remember when FIU was a 2-year commuter school, okay? Not a research institution, nowhere on the map. The name of FIU, no one would put, if you made people guess, same person on the street interview, made people guess, where is Florida International University? No one would say Miami in 30 or 40 years ago, 25 years ago. People might still be hard pressed. I don't know who decided to name our universities. The University of South Florida is in Tampa. I mean, Florida Atlantic University is not on the ocean. It does not make sense, but that ship has sailed. Those ships have sailed. Let's hope that they have water to actually sail on. But I want you to know how proud I am to have been part of and watched the evolution through my nearly 32 years as an elected official in our state and 3 legislative bodies. So I will continue to cheerlead, not just on the sidelines, but on the field for FIU's success and to help you quarterback moving us forward so that we can really make a difference and affect people's lives for the better. Thank you so much.
Thank you, Congresswoman Debbie Wasserman Schultz. Thank you for your advocacy on these important issues. This is why we love you so much. And you go across both sides of the aisle in bringing home the things that are important. And after all, there is nothing more important than the health of our people and the environment in which we live. And together, we are going to do everything to make it better. So thank you. So that really is the end of the sessions today. Sorry for the little fire drill. It was just a test to make sure we all evacuated when we were supposed to. It has truly been an honor to be with you today. This center, I want you to consider it your home away from home. So anytime you're in Washington, D.C., please come in here and use the offices and meet with the people. It's a great facility. And the things that we're doing here are truly transformational. I mean, this is a very impactful afternoon. And I would think that a conference lasting 4 or 5 days, honestly, would not have quite the impact that these last 3 or 4 hours have had on so many people. Again, thank you to all of our speakers, to the panelists. Enjoy the reception afterwards. You can be here as long as you like. The staff is here till 11. Carlos will be here till 11. And enjoy. Thank you again. They're always so wonderful.